I'm Ambre Lucidi. I'm here with Professor Anders Troelsen from Copenhagen, University Denmark. So we're very happy to have you here in Toulouse at PCO. So you're a well-renowned hip and knee replacement surgeon. You're well-known in research, surgical education, and mentorship. You're the actual European Knee Society president with the upcoming Congress in September in Copenhagen.
Yes.
So welcome and thank you for joining us today.
Thank you for having me. It's a great pleasure.
So this afternoon we will embark with you on the virtual fellowship in Denmark in your practice regarding UKA cases. So what can you tell us a little bit about your current practice?
So it's very much based on the unicompartmental knee arthroplasty. So for me, the workhorse operation is the medial uni. So I do that in around 50% of my cases. I do another 15% laterals and some PF. So from that, you can already see that I'm a uni fan. So
That's
I do
true.
2 out of 3 as a unicompartmental knee arthroplasty.
Very nice. So what do you tell your patient when they come in your office and you see the indication for UK? What do you tell them?
Yeah. So obviously for me, it's about recognizing the pattern that they have. And for me, I see it as an opportunity to personalize their treatment, right? I talk with them about the outcomes that we have and that we see in the research, so that we have improved patient-reported outcomes, we have lesser morbidity, lesser mortality, faster recovery. And then I think often the patients ask, so what about revision? Will I have the same revision rate as for TKA? I say, if you have your operation done in a contemporary practice by a surgeon doing enough, using contemporary implants and techniques, then you can actually, your revision rate will be similar to TKA. So I think I try and make them alert that there's a new situation, dynamic situation, which is, improving aspects for unicompartmental knee arthroplasty.
So your UKs, what would you say would be your revision rate to total knee arthroplasty?
So for me, it's similar, it's the same. We have different kinds of revisions done. So early revisions for TKA would be the horrible infection, and for unis it's something different. We have bearing dislocation, we have fractures. So you have different scenarios. Also, it tends to be so that a uni dislocation, for example, is a very, very limited thing. You have quick recovery after revision and so on. For me, it's the same. Nationally in Denmark, we have a high utilization of unis, and we're starting to see that nationwide they're getting very close to each other, the early revision rates. Very encouraging to see.
Great. So what would be your tip to give to make a UK successful more on a surgical point of view in the OR?
Yeah, so I think we know from the data that the surgeon doing it must do enough. So that's number one. You need to dedicate yourself. You need to go to see someone to learn the procedure. You need to master the technique. I would say have a colleague that is doing it also, someone to talk with, someone to discuss cases with, indications and so on. And then I think that's the one thing. And then the second thing I would highlight is the indications. So it's very simple. It's AMOA, anteromedial osteoarthritis, very few contraindications. So you should be able to see yourself getting to very high usage very fast. Mm-hmm. So dedicate yourself. I think that's number one.
Okay, very nice. So what would you tell a young surgeon starting in UK? Because I think it's very different in Europe, the view of UK. Some countries, and I think about more Nordic countries, have quite a usage of UK, but some residents in certain countries do not have the opportunity to see these UKs. Yeah. Some surgeons will say to their patients, don't go UK, go directly TK, so you have one-stage surgery versus a two-stage surgery. What would you tell them?
So I would say to our younger colleagues who wants to start a uni practice, I say, the data is there. So the evidence suggests you must do this. There's consensus statements now growing between European Knee Society, British Association for Surgery of the Knee, stating that you must do this. Not only is it a suggestion, you must do this now. So I would say there is the data now. You have a golden moment now to use the evidence to get your practice going. So use that, and then I always encourage people to get into a network, get to know other colleagues around you that is doing it. You need to meet with them, you need to talk with them, you need to learn from them. So get into some local network, go to the international meetings like the one in Copenhagen in September.
Exactly.
So you get up to date with what is people thinking about uni, what results do people talk about. So you get into your contemporary setting with your practice, and I think that's super important. But the young guys and girls and boys and girls, they are the ones who can change the world. That's what I'm going to say.
Fantastic. What about your take on robotics and UKA?
So I think with my current practice, if you ask me, do you need it? I would say no, I probably don't need it. The instrumentation that we have, the techniques and approaches that we have are now so, we're being helped so much as surgeons, we're being helped being accurate. Our resections on tibia are now conservative, and we have so much help from the current instrumentation. I see a very good future for robotics in terms of making us more accurate. So if I told you I want to do a 2-degree varus cut on the tibia, how would I do that, right? So I need ways to help me being that accurate. And I think that's where I see a future, right? So helping us being more accurate and in executing the plan that we want to do.
Do you see a future in maybe a personalized UKA?
No, sure. For me, every UKA operation is personalized because you look at the morphotype of the patient, the wear pattern, and based on that, you choose the arthroplasty you want to do. That's the biggest level, right? Second level, I think, is where you start looking at the anatomy. You start actually positioning the implants in a way that also facilitates and helps the kinematics of the knee. And that's the second level. And that's, again, we talked about robotics just before. Maybe that's the position for robotics.
Okay, great. What about combined procedures? So double UKAs, UKA combined with ACL reconstruction, and UKA with patellofemoral joint replacement. Could you touch a little bit on that?
Yeah, sure. So for me, using the contemporary indications and contraindications criteria, so it's only if you have very severe lateral facet PFOA that you cannot do the medial uni, right? So remember, I have a very open view on doing unis also in various degrees of wear for the PAT-FEM. So I don't feel a need to do patellofemoral and medial and laterals together, right? So it's very limited. I've done on rare occasions bi-unis, so medial and lateral, in a young patient with a certain need to preserve the ACL, looking ahead at the rest of the life of the patient. I think it makes perfect sense. So just like doing a primary uni, I guess. And then for the as much as I can, I try to really push for the medial or lateral uni. If you have a OA progression, you have a medial uni that's been working well for a number of years, then that's a good position to put in a lateral uni on the other side. So like a delayed lateral uni, supplemental lateral uni. There's some evidence there suggesting that's good, that works well.
So PCO is also about mentorship.
Yeah.
So what was the advice given by one of your mentors, or what advice would you give to us young surgeons in this field?
So you need to have many mentors. You need to seek different mentors. So through your career, you will meet different people, and they will be your mentors. But you need to move yourself sometimes to meet those mentors. So that's my number one thing. Travel, go out, see the world, meet people, and meet your different mentors out there. I think that's number one. And then be a gentleman or gentlewoman always, right? Be kind to each other in the teaching situation. Always be kind. Also, I would also put emphasis on, I expect something from you in this situation. What do you expect from me? An exchange of, of respect and of knowledge. Yeah.
Fantastic. Well, we look forward to you embarking with you in this virtual fellowship this afternoon. Thank you very much for your time, and thank you for joining us.